Welcome everyone to our discussion on the role of HRD testing in cancer. Today we dive into the intricate landscape where genomic insights intersect with cancer treatment, shaping the future of personalized medicine. We have with us Dr. Uma Dangi, Consultant Medical Oncology, Fortis Hospitals, Mumbai. Dr. Uma Dangi has received her medical degree from Grant Medical College, Mumbai, completed her DNB in internal medicine from Dr. Amit Cooper Municipal General Hospital, and her DNB in medical oncology from PD Hinduja National Hospital and Medical Research Center. She is a medical oncologist with over 10 plus years experience with a specific focus on women's cancer, blood cancer, genitourinary, and gastrointestinal cancer. Aligned with the latest medical advancements, she is dedicated to bringing precision oncology to cancer patients. We also have with us Dr. Kunjal Patel, Consultant Molecular Oncopathologist, Neuberg Center for Genomic Medicine, Ahmedabad. Dr. Kunjal completed his DNB in laboratory medicine and pathology from Deenanath Mangeshwar Hospital, Pune, and postdoctoral fellowship in molecular oncopathology from Tata Medical Center, Kolkata. He has 9 years experience in pathology and he specializes in solid and hematological cancer genomics. He leads the Department of Molecular Oncopathology, Solid Malignancy Division at Neuberg Center for Genomic Medicine. His areas of special interest are cancer biology and genomic informatics. A very warm welcome to our panelists. So to begin with, my first question is to Dr. Uma. What is homologous recombinant deficiency testing and why is it important?
So if you've, in the last few years or maybe a decade or so, oncology has been a very fast growing science. And what has happened is our understanding of the disease itself or the biology itself has grown by leaps and bounds. So now, before cancer used to be a death sentence, we were trying to figure out why it happens, how it happens, all these things. And now, with the help of molecular biologists, we are able to understand, there might be certain mutations in particular cells, which are probably leading the growth or driving the growth of a cancer cell. And because of this, now we have the era of what we call as precision oncology or targeted therapy, where we try to figure out the mutation which drives and try to target that particular mutation with the drug, etc. So HRD is one of the things that we can test. So HRD is what? So a human body is made up of different cells, and our cells are constantly being subjected to some kind of stress or the other. And because of this stress, there is damage to the DNA. So cell divides every time or replicates, and during this process, there are bound to have some mutations, and there is a machinery within the cell itself which usually will take care of these mutations or these abnormalities and corrects it. So either it will repair the damage so that the subsequent cells are normal, or it will kill the cell, or there will be something called a cell death. So now these various mechanisms in place for repair. One of the mechanisms is a homologous repair. So that is how the certain breaks or double stranded DNA breaks are being repaired. So when a particular cell is deficient in this area or in this homologous repair, then this cell cannot repair itself, and it starts to use other sort of other pathways to kind of get repaired, which are error prone, and it leads to this cell probably developing many more mutations leading to cancer. All right. So what we try to do, so when we detect this HRD, that what it means is that this particular cell is deficient in this particular repair of the DNA. Now, this can be of two ways. One is we all talk about BRCA1 and BRCA2, especially, in breast cancer and ovarian cancer. So BRCA is one of the, so there are multiple genes which are important for homologous repair. and BRCA1 and 2 are probably the most important ones in this regard. So, so this can be something which can be genetic, as in it can be inherited from your parents or grandparents, where your all your cells are defective, and which is why you are prone to developing maybe breast cancer, ovarian cancer, prostate cancer, pancreatic cancer. Or it can be a somatic mutation. So somatic mutation basically means that it is only present in the tumor cell, it
Right.
is not present in all the cells. So these two ways we can find out whether a particular cancer is deficient for a homologous repair. So if it is homologous repair deficient, then I can target it with newer drugs or with newer therapies which are directed towards that particular deficiency, so that I can improve survival and I can give better responses to the cancer. So basically, in gist, that this is what is homologous repair deficiency.
Definitely. So I would like to know the lab perspective, Dr. Kunjal. How and why HRD is being measured currently in leading labs?
So basically, compared to other concepts, HRD is a very complex process, and most of the medical fraternity is very difficult to digest that what is happening at the genome level. So the most important thing here in HRD is that right now what we are doing in HRD is we are taking at the three aspects. So if you ask me what is HRD, so HRD is a large bracket or large phenomenon where it encompasses many of the small phenomenons. So among the larger group HRD, we classify into three parts. First is HRR, second is genomic scar, and third is a functional defect. So if you ask me, HRD is divided into three parts: HRR pathway defect, second is genomic scar, and third is the functional defect. So right now, what we are testing in the lab is the first two aspect. The first two aspect means that first is HRR. So whenever I say HRR defect, it means that we have a set of genes. Right now, NCCN has recommended 14 set of genes, including, as Madam mentioned earlier, BRCA1, BRCA2, PALB2 check. So these are certain 14 genes. So if there is any defect in this 14 genes, then we call it as HRR pathway defect. So it is at one level only we are looking at it. So if you look at the ovarian cancer, then generally around, if you're looking at only HRR pathway defect, you will get 15 to 20% of the cases. But apart from that, another aspect of HRD is genomic scar. So in genomic scar, generally we measures three level. Right now, what we and if you ask me 2024, the 2026, 2028 would be completely different. But if you ask me today, then if you are asking the genomic scar, at that three level we are determining genomic scar. One is loss of heterozygosity, second is telomeric allelic imbalance, and third is large cell transition. So what does this three terminology means? These three terminologies are the genomic aberrations, which we are looking at a genomic level. So it is not technology, it is just aberrations. So what are these three terminology means? I would describe in detail. First is loss of heterozygosity. These are the complex phenomena, difficult to understand by even the genomic expert also. So what is less of heterozygosity? Generally, we inherited two alleles, one from parent, one from mother. So basically, both alleles are responsible for proper functioning of a cell. So in case or because of, as Madam mentioned earlier, any of this defect, there is loss of any one of the allele, either parental or maternal. Then that cell loses its heterozygosity, and now that cells becomes prone to cancerous or loses the routine stability. So this is loss of heterozygosity, which we call. And most of the labs right now are measuring LOH in most of the when they are detecting HRD. The second phenomenon, which we call as telomeric allelic imbalance. So as we all know that telomere are the end part of the chromosome. So it has two major functions. It first maintains the stability of a chromosome. So a chromosome has to be stable or it maintains its integrity because of the telomeric length. And second is aging. So as you move from 40 to 50, 50 to 60, 60 to 70 years of age, that telomeres become shortened as age advances. So because of these two phenomenon, it has very high level of significance. But in case of HRD, this telomeric imbalance is there between two alleles. So again, as I told earlier, one allele from mother, another allele from father. So if there is imbalance between either of these allele, then we call it as telomeric allelic imbalance. The second phenomenon is that. And the third important phenomenon is called as large scale transition. Now, what does this LST? There in short form, it is called as LST. So generally it is assumed that whenever during mitosis or meiosis, from one cell to another cell, when a cell divides, generally it takes 10 breaks. Now these 10 breaks are random, and these 10 breaks are repaired by the HRR genes. BRCA1, BRCA2, RED51, they all form a complex and they try to repair, and again a cell moves from one stage to another. So if this defect are not repaired, then again a cell moves into a stage called as HRD deficient cell. So these are the three most common phenomena right now we are measuring in a routine lab. So when you ask, each lab has different. Suppose you ask me foundation one. So foundation one generally measures LOH only, and they give a score. If you ask me myriad, so myriad measures LOH, TAI, and LST, all the three. So this is a second phenomenon. First, as I told earlier, HRR pathway defect, where certain set of genes, some take is 14 genes, some take is 20 genes, but 14 genes are the optimal. The first part. Second part is genomic scar, but these are the three most common abnormalities right now we are measuring. And the last one is HRD functional defect. Right now, as of 2024, it's very difficult to assume, and most of the labs, no one does it. So right now, if you ask me HRD, two aspect, HRR and HRD. So in our lab right now, we are doing HRR. HRR is a relatively cheap test where somewhere around 15,000 you can do sequence all 14 to 15 genes, and you give a result whether it is positive or negative. If it is negative, you call it as HRR pathway defect negative. If it is positive, you call it as HRR pathway positive, either BRCA1, BRCA2. You have a label to that, and patient is eligible for HR PARP inhibitors. And second is HRD, which is comparatively a costly test where different techniques are used to measure these aberrations. And again, here it is score is generated. So now different confusion is there. What is HRR? What is HRD? What is HRD score? So HRD is a phenomenon, and each lab has its. And whenever I say HRD score, so each lab designs its HRD score. So for my lab would be different. For foundation would be different. For myriad would be different. So score and HRD is a concept, but HRD score is a lab validated score. So these three terminologies moves around whenever we are discussing HRD.
Right, right. So that is a very comprehensive view. So Dr. Uma, can you tell us about the clinical aspect of HRD, that how it acts as a predictive and prognostic biomarker in ovarian and other cancers?
Certainly. So, having understood the whole concept of HRD, what we are seeing now is that, see, these cells are already deficient in a repair pathway. So, if you give them additional stress, they are very sensitive to apoptosis or cell death. So, these patients are known to be very sensitive to certain chemotherapeutic agents like platinums. And if you look at so this is something like predictive. So predictive basically means that how well it will respond to a particular therapy. Prognosis, it tells me how the survival is going to be. So if you look at the predictive value, so like I said, they are very sensitive to platinum agents, the common chemotherapy agents that we use. In addition, they are also sensitive to certain drugs we call as PARP inhibitors.
Right.
So what is PARP? PARP is an enzyme which is important for another repair pathway. And what we the using the drugs which inhibit this pathway lead to a phenomena called synthetic lethality. So what it means is, you have one part is already defective, one pathway for repair is already defective, so the cell is relying on another pathway. If you sort of target the other pathway as well and stop that completely, the cell can't repair itself and has to undergo cell death. So that is what it means. So one is defective, you block the other one as well, and the cell has no way out but to die. So this is how the synthetic lethality works. So having a HRD, it predicts sensitivity to platinums as well as its sensitivity to PARP inhibitors, and which are coming in a big way in breast and ovarian cancers as well as prostate and pancreatic cancer. Coming to the prognosis, now these patients have actually a little better prognosis in terms of survival, progression-free survival as well as overall survival. They have a little better prognosis because they are so sensitive to the therapies offered. So prognostically, they're probably a little better. But yes, if it's a hereditary or a germline mutation, then definitely you are going to be prone to developing, like if you have had a breast cancer and if you're BRCA positive, then you might also develop ovarian cancer. So, we have to look at the whole aspect of it.
Right. So, Dr. Kunjal, can you describe the molecular techniques used for HRD testing?
Right now, as a molecular lab, has a lot of techniques inside it. So if you ask me in molecular lab, with respect to HRD, the two most common techniques which are used are next generation sequencing and microarray. So in a molecular lab, both techniques are there. So initially, if you ask me, more than 95% of the labs use next generation sequencing. So next generation sequencing and microarray are the platforms. So these are techniques which is used. But initially, when this HRD initially was started on a microarray based platform where copy number variations were detected, and this copy number variation, including LOH, TAI, LSD, were based on the basis of that. And finally, as we move forward, this NGS came way good into the picture, and it overcomes most of the techniques right now which exist. So previously we used to say that some of the things could be detected only on microarray, but as bioinformatics, this AI driven program and everything is moving fast forward, NGSs and bioinformatics pipelines are strong enough today so that most of the things are done on NGS platforms. So basically, right now, in most of the times, we use NGS as the most common technique right now in that. And important aspect is that first of all, how we process this part in that. So generally, the whole process of HRD roughly takes around 8 to 10 days. So initially we started with FFP block, the histological block on which tissue diagnosis of cancer, prostate cancer, has been done. From that FFP block, we extract DNA. But before extracting DNA, it is essential that few of the prerequisites are there. For as a lab test, any a lab test have P analytics. For that, at least more than 30% of the tumor cell should be there. Higher the number, better is that, but at least we should have tumor selectivity of 30%. Why 30%? Answer to this is that 30% is number that will sufficient to measure this kind of aberrations or genomic scar, which we call LOH, TAI, and last cell transition. So 30% is minimum. And second, another important aspect is that the tissue should not be old. It doesn't say that what is the, no one can say that how much old is sufficient, but at least we assume that up to 1 or 2 year is sufficient. But more than 2 year, it is very difficult. But you can't say that it will not work. Many of the times we have in our clinical practice, we have tried and still it has worked better. So second is the age, and third is the preparation of a block. Suppose 10% formalin. When we are preparing a block, we need 10% formalin. So if 10% formalin, the quality should be good. Then we find less failure rates. So if you have seen in HRD, somewhere around worldwide phenomenon, 10 to 20% of the times we are not able to provide the results. Why this 10 to 20%? What are the reasons? Reasons are that formalin preparation is not good. During a block preparation, it has to pass through a wax. If the quality of wax or paraffin is not appropriate, then also the DNA get double stranded and it's break. Apart from that, alcohol which are used during this process, if that's the small subtle things. If they are used properly, then we are able to get better, good quality of results. So after DNA extraction has been done, so right now around the world or in clinical practical diagnostic purpose, we are using FFP block. But yes, from fresh frozen tissue or from fresh tissue also we could use and perform HRD. But right now for practical purposes, we have only FFP block as a choice. And after that extraction has been done from FFP block, it takes around somewhere 1 day. After that, we call it as a library preparation. That is, before going for a sequencing, it has to go through a process called as library preparation. So somewhere around it takes 2 to 3 days. A library is prepared, and after that library preparation, it goes into sequencing. That is next generation sequencing, where our suppose we are detecting HRR, then the whole ATGC or all sequence has been sequenced. And apart from sequencing, genomic scar are identified. And after that, it roughly takes around 2 to 3 days for a machine to get sequenced. Now, in this sequencing, also lots of instruments are there. But the most commonly and standard of care instrument which we are using, or everyone, most of the labs uses Illumina sequencing. The Why we are using Illumina? Because it has low error rate. So whenever you are sequencing ATGC, the error rate of this instrument is low, and because of that, it is preferable. And after sequencing is done, somewhere around 1 to 2 days is taken for analysis. Now each molecular lab is divided into two aspects: wet lab and dry lab. So wet lab is up to NGS sequencing, and after that, a dry lab where most of the things are done on computers, large server, and things that we call as a dry lab. So roughly around 2 days is taken care by dry lab perspective. So 8 to 10 days we are able to get HRD results. But the most important practical question is that why labs are taking 15 to 20 days for giving the results? Most of the labs we need to pull the samples. We cannot take like CBC, you take one samples and you run it. At least we need minimum 8 samples for a batch to run. So basically most of the labs are accumulating this 8 samples, and either at the mid of the week they are running, and because of that the turnaround time somewhere goes around 20 to 30 days. Otherwise the process itself takes somewhere around 8 to 10 days from start to end. So this is the
Right.
whole turnaround time.
Right. Correct. So, Dr. Uma, how safe are PARP inhibitors, and what is the approximate percentage where you need to stop PARP inhibitors because of some adverse effect?
Yeah, so some of the time, even if you talk about targeted therapy, people are usually patients are very happy when you tell them you don't need chemotherapy and you need targeted therapy. But targeted therapy is not without side effects, and PARP inhibitors are also inclusive of that. So what we most commonly see with PARP inhibitors, the toxicity is mainly a lot of fatigue. So many patients have severe tiredness, fatigue. They feel lethargic and they don't want to do anything, just that really impairs their quality of life. Also, some of them can have severe nausea. They're not able to eat, they lose taste sensation in the mouth. Some of them can even develop sores in the mouth because of the drug. Other important side effects include, the WBC platelet. So, it's a common thing that, with chemotherapy, goes down, your WBC, hemoglobin platelet go down. But even with PARP therapy, these side effects are known, especially severe anemia, your hemoglobin being low, WBC count going low, platelet counts going low. All these have been seen to occur with PARP inhibitor therapy. Rare cases of even second cancers like MDS and leukemias have been known, although the percentage is less than 1%. So, but it is still known to occur with the use of PARP inhibitors. As far as discontinuation is concerned, many times what happens is you start at a higher dose, but you end up modifying the dose. Because as patient is not tolerating a particular dose, then there are guidelines in place which tell me, okay, you reduce the dose for one level or two levels and see how the tolerance improves. Sometimes patients do improve in their tolerance, in the sense that the cytopenias come down, the fatigue resolves. So all these things, the quality of life can improve with a lower dose. But yeah, but in some patients we have to discontinue. So roughly about the discontinuation rate may be anywhere between 15 to 30% in worldwide. So there are discontinuations because of toxicity, and of course even because of the disease progression sometimes.
Right. So, Dr. Kunjal, how do you analyze HRD testing results and determine the HRD status of a patient's tumor?
So basically, just now I will be talking more about the post analysis. So this is a proprietary technique. So most of the labs right now, if you ask me, what are the FDA approved labels? So right now, two labs have FDA approved for HRD. One is Myriad, that is my choice companion diagnostic, and second is Foundation One. So for Myriad, all the three genomics are including LOH, TAI, LST are approved, but Foundation One checks only LOH and they are able to give the results. So these are the two proprietary things, and they are very costly tests. So no, if in a country like us, not everyone can afford 2.5 lakhs test. So over the country wise, many apart from these two companion diagnostic tests, many labs have tried to develop their own test, and they are also similar as HRD, and have to have a comparison with the original that Paula solo trial. So somewhere around more than 90% of the time, if they are able to achieve the comparison or sensitivity of good, then we launch it. So right now in India, if you ask me, apart from these two, MYDX and Sophia Genetics. Sophia Genetics is a European-based company where we are able to detect HRD. So in this, we are whenever two aspects are there. First aspect is that we give HRR gene mutation. As I told earlier, HRD is a broader concept. For this HRR pathway, 14 genes are that patients are eligible for PARP inhibitor. And second part is HRD score. So in HRD score, our cutoff is 1. So if it is greater than 1, then we call it as HRD high. For Foundation 1, it is somewhere around 16. For Myriad, it is 43. Now, Myriad has changed from 43 to 33 because of many of the reasons. As advances, the data gets more matured and they have come to a certain next level conclusion. So, it is a completely benefited by providing this score. So, as I told earlier, in our we have two settings. One is HRR pathway defect, HRR gene mutation level, and second is HRD score, where our cutoff is 1%. Where if it is greater than one, we call it as HRD positive, and patient is eligible for PARP inhibitors.
Right. Right. So, Dr. Uma, what do you see the future direction of HRD testing and PARP inhibitors into clinical practice apart from the cancers we have already discussed?
So definitely, I think, as we learn more and more about this aspect of aspect of oncogenesis, I think it will definitely hold a promising future. It's already approved in breast and ovarian cancers, and it's already upcoming in prostate and some pancreatic cancer as well. So definitely, which as we understand the biology of different cancers, we have to understand which cancers are more likely to be driven by this particular pathway. And, those are the cancers we probably target to analysis as well as, to treatment with PARP inhibitor based on the results that we get. Now, most of the times, in metastatic or advanced disease, we end up doing a NGS or a next gen sequencing, like Dr. Kunjal said, and where we do run a broad panel which already gives us a lot of other information along with probably including these genes. It may not do the LOH or the other method that Dr. Kunjal mentioned, but it does include the genes which are responsible for HRD. So definitely, as we learn more and more, we are going to probably find more and more indications to do the test as well as to use the PARP inhibitors.
Surely, I fully agree. So, Dr. Kunjal, how will whole genome sequencing change the HRD testing?
So right now, whole genome and whole exome. When you talk about cancer genomics, if you talk about general genomics, then it is fine, where whole exome and whole genome is comparatively routinely done. But when you talk about cancer genomics, somewhere around 1,000 genes are related to cancer. First of all, whatever knowledge as a scientific community is very limited. So out of total 20,000 genes, only 1,000 cancer genes were able to associate it with cancer. So most of the panels right now, what we are doing is related. It's less than 1,000 gene only. Someone do 5,000, 500 genes, 600 genes. But beyond going that point doesn't make much difference right now. But apart from that, so for one aspect is that either you do 1,000 gene sequencing and you come to a certain conclusion, whether, as Madam told earlier, target therapy, whatever targets are available. But when you're talking about HRD right now, many of the panels, somewhere around 10 to 15 different publications are there where they are doing whole genome, whole exome sequencing when and trying to identify, apart from targeted therapy, apart from HRD, are we able to provide any other genomic signature which would be helpful, whether that pembrolizumab is useful in that, or genomic different kind of genomic signature. Yes, medical fraternity still research is going on, but if you ask me about the HRD perspective right now, whole it's a promising future, but in 2024 still it is not up to the level where we could say that yes, you could do whole genome sequencing and you're able to get better HRD. Yes, in of course in the future it would be there depending on informatics and this, because right now lots of things we still are using in our lab where human or our brain cannot comprehend that part, and easily it is within fractions of second it is been done by the computers right now, and different statistical models are placed in the picture. So when I was doing pathology, it was around just cells and looking, but right now my 70% of the times goes on computers. So as a pathologist as well as for medical fraternity, more of the times are going through our screen based that algorithms. We have to go through that part. So definitely by, I think, assume 6 to 7 years, we will have the whole genome sequencing as an answer, where apart from mutation level HRD and many other mutational signature, including methylation and many other genomic signatures are there, which would be helpful in when we are treating as a cancer patients.
Right. So, Dr. Uma, are there any ongoing clinical trials or drug molecules other than PARP inhibitors in HRD positive cancers that you find particularly promising?
Actually, a lot of work is going on in PARP inhibitors, and then also, but it's more of immunological signatures. A lot of people are looking at targets for immunotherapy, like you had PDL1, now you're looking at TIGIT. Then now, like for HRD, however, I think PARP inhibitors are the one which are being explored more extensively, and definitely there are ongoing trials. They are trying to find new indications. They're trying to find better molecules. So, when the first drug comes out, because of the toxicity or because of the side effects that we see, we try to be more selective with the newer drugs to kind of sort of reduce the side effects. So definitely newer, so second, third generation of PARP inhibitors will continue to come to try to reduce the, sort of balance the toxicity with the while still maintaining the therapeutic effect. So there are definitely many ongoing trials, phase 3, phase 1, to look at the role of PARP inhibitors.
Right. So, my concluding question I will shoot to both of you, that how can we increase the awareness among clinicians and patients about BRCA and HRD testing to optimize treatment decisions and improve clinical outcomes for newly diagnosed cancers like advanced ovarian cancers? So, Dr. Kunjal, first, you tell me the laboratory aspect, and then Dr. Uma, you tell me the clinical aspect.
Because I think most of the times educational training, CME are the most important aspect. Where when I see the newer generation clinicians, because I get samples from all over India, newer generation of clinicians are easily favorable for, but it's difficult for the older oncologist or senior oncologist to convince them. But I think sooner or later, it takes somewhere around 4 to 5 months to patch. Otherwise, I think CME trainings and that things are sufficient. Apart from tumor boards are another aspect where we could collaborate, where we could have a discussion and come to a conclusion. And apart from that, I think affordability is the most important issue. Apart, everyone wants to do HRD, but whether that's 80, 90,000 tests is affordable to our patients, that's the most important question. So many clinical trials where companies are giving coupons where if you opt for that, then they are at a very consistent price. So I think if it is covered in insurance, then it would give a better boost to HRD. These 2 to 3 aspects, which I considered as a significant when looking at how more often this test could be used for patient care.
Right. And Dr. Uma, any special comments?
No, I agree there with Dr. Kunjal very. I think CME education, and nowadays social media is a very good platform where everybody has access to social media and people are constantly on whatever those apps are. So if you want to make patients aware, then having creating these sort of like how you have created this video or creating these awareness campaigns, putting it on social media or putting it in the news. And I think government can also try to play a role here where they can educate the masses as well as allow it to be a part of the normal testing that we do, like for the approvals for certain tests, especially patients who are under government scheme, approval for the tests to be done, approval for the drugs to be given. So if all this comes through, then I'm definitely I think we can access there will be more access to these tests as well as drugs.
Right. With this ray of hope, I conclude today's session. Thank you, our panelists, for joining us. Thank you.
Thank you so much. It was a pleasure to be here.
Thank you.
Thank you.